Our next talk will be by Dr. Sabine Ernst on the non-invasive 3D mapping for VE and VT ablation.
Dear Richard, dear ladies and gentlemen, dear Julian, I think he had to vanish quickly.
Our thing for the question and answers has frozen up. Julian had to go get somebody's password so we can log back on.
Perfect. So thank you very much, first of all, for having me. And I'm talking to you about mapping, but non-invasively. And of course, this is a kind of a quite elegant way, if you think about it. If you could find the place of an ectopy or a VT or even any kind of arrhythmia without even touching the patient, without bringing him to the lab, without invasively putting into that person's heart and have a high accuracy, that would actually be very, very elegant. And that would be ideally shortening our time in the lab later on if we can say, okay, we can do something, we can localize it. And we could possibly plan the whole procedure very well by making sure that we have the right approach. We know if it's an endo or an epicardial location, and the whole setup, the team that takes care of this patient will probably be better prepared. Now, if you think about ventricular ectopy, you could say, okay, most of the time the people that we get referred are outward tract arrhythmia. It's not so dramatically different. You learn your algorithms, you try to understand where it's coming from. But it's actually quite good if you have an idea of endo versus epi ahead of time. Now, there are patient groups that have a higher chance for that. Pierre just told us about ARVCs. They're probably quite elegant to know and couple that to the fantastic FDG imaging that you've shown us. But that's, again, would be great to put it all together. Now, we do this, you could argue, from a 12-lead ECG of the documented arrhythmia all the time. That's what we do in clinic, right? We try to put this in our heads together with the anatomy of the patient and try to find where it is. But there are actually systems that help you with that. And I'm going to talk about two systems. One is the ECView system that was initially CardioInsight, by now it's Medtronic. And I'm going to talk much more about the Vivo system from Catheter Precision. Both tools allow to localize the arrhythmia in a non-invasive way. Now, CardioInsight works with a big, basically body surface ECG approach with a vest with 252 electrodes that you put on the patient's chest, on the front and on the back. We have smaller vests for smaller patients, bigger vests for bigger patients, and then we do a CT scan to locate the ECG electrodes and to get, in a non-contrast scan, also the cardiac anatomy. So we have these two things that we are basically putting together. We know exactly where the electrodes are from the ECG, and you see that here on the right-hand side. That is shown here with the green dots, and you basically, I hope that you see it. You see it? No, wrong thing. Maybe here. Yeah. So the green dots here are marking exactly where those electrodes are here. Unfortunately, this is not compatible with an MRI scan, but you have to do it on a CT. So the patient is exposed to radiation at that time, but you can basically, in a actually not too time-consuming fashion, locate the surface ECG electrodes and then have the 3D reconstruction from either the ventricles or the atria for the CardioInsight system. And then you basically can follow this patient. You can monitor this patient for, I think, up to 8 hours by now on the ward, for example. Yeah, or even in an outpatient clinic setting, and see what the patient produces. Let's say the patient has rare ventricular ectopy, but is very symptomatic. And you could wait for it to happen. You could provoke this patient, for example. You could challenge them with, meeting their favorite relatives, or have them being stressed by a stressful phone call, 3 cups of coffee. IV isoprenaline, whatever you could think of. You could make them exercise and see exactly every heartbeat. Every single heartbeat can be reconstructed. You would just need to select that on the system. So that is very helpful for patients with either very rare arrhythmias or transient arrhythmias that are hemodynamically, for example, not well supported. Now, we had studied, that is some years ago, we had studied at the Brompton 50 patients Nearly half of them were congenital, and we had actually quite good success. I think many other groups, especially here in London, Hammersmith has studied mostly RVOT patients, but we actually took basically all comers. Some of them had really quite difficult presentations, and we really found that the system was very helpful. We used it for ventricular and for atrial arrhythmias, and you can see even in the congenital group, we had very good outcome with 92 and 88% of clinical success. We could actually also identify patients who, despite the fact of reporting typical palpitations, we could either not induce at all in the non-invasive phase, and actually at some point I stopped taking those people to the lab, because if you try for 8 hours to try to provoke them on the ward whilst they're awake and not sedated and not exposed to any kind of anesthesia, this will not happen in an EP setting even better. Now, we tried the other ones, we tried and burst paced them, and we did not get anything meaningful out of them, besides 2 patients where we induced atrial fibrillation only, and again in a congenital setting that is very, very difficult in advance, and I did not proceed in these patients to do AF ablations. So it actually helps quite good to identify patients that you can actually treat. Now, the Vivo system works from the mindset in the same kind of level, but it takes only a 12-lead ECG. So it does essentially what you do in the office, a little bit more sophisticated, and importantly, with the individual anatomy of the patient. That is the key feature here. So it combines a model, and I show that to you here. And at the moment, we're concentrating on premature ventricular beats and on VT exit sites. Now, here is basically the hardware components on this. First of all, you have any kind of 12-lead ECG in an electronic format. We have to image the patient. We can take a CT or an MRI scan. In fact, we would like to do an MRI because it gives us a nice field of view. We need to have the shoulders in the picture, and that is a bit nicer if you don't have to do the large field CT scan, and obviously saves radiation. And then, and that is the trick, we take the location of the surface ECG here with a 3D camera, which is actually a Kinect camera. So it really comes from your PlayStation kind of situation. So you can borrow that from your kids. And that allows you to exactly locate those ECG patches on the anatomy of the patient. Again, the DICOM data from the CT and MRI scan is 3D reconstructed. And with the sophisticated software, we can then go and identify the origin of every ventricular ectopy or the VT exit site. Now, if you think about it, how often, especially in an EP lab, do we actually have the 12-lead ECGs, especially the chest leads, in the right location? How many times do we compromise by putting the patches slightly different? Because we maybe have to put the reference patches, we have to have the defect patches. How many times I believe that V1 is in V1 position, but it actually is not? So many times that is actually the case, at least in my lab. I occasionally got trapped in this. And having a picture and seeing exactly where it is actually helps with making these mistakes where you think you need to go more lateral or more septal, where that is actually helped tremendously. Now here again, you show the same thing. We basically preparing the software, preparing the DICOM model like this with the isochrones here is slightly time-consuming now. I think the next software step is going to make that easier. But essentially, you can then choose any beat right down here that you can identify. And then you have a 3D reconstruction. So there's an accuracy study, that's an FDA trial in the US that is essentially now finished completely, where they looked into the spontaneous PVCs, they also paced and compared that to physician's assessment and also the information from the 3D mapping system that were used then in the invasive phase as well. These are the centers that participated. We did not participate, unfortunately, but Leicester from the UK participated. And actually, it was very accurate to find the location. Very accurate still to get in the right chamber. If you look into where would we get it wrong, we would get it wrong of the septal or in positions. And it was better than manual reading. And I think it is better than manual reading because you have the anatomy, the individual anatomy of a patient, where you have the full axis rotation. Sometimes we underestimate the rotation of the heart, and that gives us the wrong side, especially in outflow tract locations. Now, if you look here through the different areas of the heart, sorry, that was probably not yet what I wanted, then you can see that for some areas, the critical, difficult area still is here, the right coronary cusp. Again, if you think about where it actually is, then there's such a crossover still with the right ventricular outflow tract, and you would say, okay, that's what we learned. We would map probably the right ventricular outflow tract, and if it's not from there, and we're not really early there, we would go anyway now to the anatomically opposite side in the right coronary cusp. But I think that is still pretty good, yeah. And it gives a little bit of a preparation maybe to say, okay, this is possibly where we need to look in better reconstructions. And I should also say that at the moment, the reconstruction of the cusp area itself, as it is an extracardiac structure, that's not really that well supported by the software. And by pushing that a bit higher up, I think we're going to get better in this. Now, the FDA trial was in patients with structurally normal hearts and with scars less than 10%. Now, at the Brompton, we have lots of complicated patients. So we actually had a lot of patients, and we have now 13 patients studied with the system that are having either ischemic substrates, congenital substrates, or dilative cardiomyopathy. So we only had less than half of our patients were normal. And we were actually able to localize in all of those patients the PVCs. We were quite good. We also looked at pace beats. We looked at various locations, and we cross-correlated that then to the invasive study that we did, because we obviously wanted to treat the patients in the end, so not only a diagnostic, but we had a very nice match of 92%, if you want. So I'm going to show you some examples. This is actually one of the first cases that we did, actually the first clinical case where we really only started with that, and it was a papillary muscle location, and that actually fitted extremely well with our cartomap, and we were very happy because that would have been technically quite difficult. Now, for all the American colleagues in the room, you will say, okay, that is a plan. I would plan this with an ICE catheter. Yeah, that would be a nice feature to know ahead of time. At least in my hospital here in the UK, I have no access to ICE, so I need to make do around this, and that obviously makes the case more challenging. This is, that's our case match. We had the best PASO match, and then we had a nice warming up during the procedure. A second case I wanted to share with you is to show the combination that we can do with other tools. Of course, we can use, and I personally like to use stereotaxis. CARTO RMT here is what we did. This was very nicely localized by the Vivo system. We knew where to go. Then we went with the magnetic system single catheter approach here across retrograde to the area just below the aortic valve, sorry. And then we're very easily and elegantly able to go to the best pacemaker side, very nice, and warming up again, as you can see, during the RF delivery. Very nice and stable ablation. Now, this is a patient, I think one of the last cases that we've done with the system, which is interesting because this patient was tried twice before in a different hospital here. And she came with quite a lot of, I think, a VE burden of like 30,000 beats in 24 hours, where you say, okay, really? Do you need such a sophisticated system? You need to spend the money on this, or is that actually really necessary? And the reason why I asked her to undergo Vivo mapping was that I wanted to see if we could learn ahead of time why colics failed. So this patient had a first ablation procedure from the RVOT, and in the second case, the operators went in far more aggressively. It's a young woman, and mapped the interventricular vein as well, and used a cryoprobe in the end because they felt that they couldn't make a lesion deep enough to get rid of that origin. And first of all, I'm always hesitant when I take referrals from patients that have failed several times, and you need to make it work. You need to be successful, of course. So I asked the patient to undergo an MRI scan for several reasons, but the first reason was to get a 3D reconstruction, to understand if there was an anatomical barrier of some kind of situation that made these two very valid attempts of alpha tract ectopy unsuccessful. I also wanted to see how large the LGE scar is. So how big would that still be if she had still such a high burden? And we did, of course, the vivo mapping. And I show you here on the right-hand side, that was the only monomorphic origin that she had. And you see that this fits very nicely to this is the pulmonary artery here to the right, at the middle in between, right there. So this would be the aorta. You don't see the aorta itself, it's not reconstructed. And the pulmonary artery would be there, and that's the red dot marks the earliest spot on vivo. Now, so with that reconstruction, with her 3D scan and knowledge, I brought her to the cath lab, and I said, okay, we're going to try very carefully. I used again stereotaxis because I can very easily, of course, drive into the right ventricular outflow tract, but I can also very, very easily and elegantly go with that magnetic catheter in her interventricular vein again. And I can map and pace map and map the local activation time with that catheter without any problems. And again, I salute the colleagues that had tried before with a relatively bulky cryoprobe. To get even to that location is not easy, and I think I've never tried, but I think it's quite difficult to even come into the distal coronary sinus. So we managed to come on both sides. We found the best pacing site, and actually the pink spots are where we ablated her successfully. That was the best pace map, and of course we ablated from the right ventricular outflow tract, and I think it was 2 burns and the whole thing went away. She has a follow-up now for over 4 months, and she's completely without any ectopy. So that was actually quite helpful to make that decision, how to plan the case. And despite the fact that she had so many extras, I think it was really helpful as well for the patient to have this reassurance. You can do that ahead of time, and actually in the next step we will be able to import this picture as a VTK file into the CARTO system as well, to guide even better in the procedure. This is one of the steps that we're going to do in our prospective trial. The prospective trial, it's a relatively small trial, but we want to also go and take not only a 12-lead, 5-second ECG, but we're going to take a 24-hour Holter, and then we can see what's the dominant ectopy, for example, which one is, how many morphologies do we have, and that's basically what we have nearly the agreement from the local RSC for, and I thank Pat Kennedy to have gone with me to Guildford recently to have that assessed. We will compare then the clinical outcome with our database from patients that I've treated in the past with the same kind of substrate, and we hope that we will show that it's going to be much faster, and we will be allowed to and able to treat far more ectopies in a shorter time, and show that it's beneficial. So let me conclude. I think it's a valuable tool. It's a new tool to do EP outside the EP labs. And that's great. I think it's great for patients with rare ectopy. It's great for patients with multiple targets. It allows us to plan endo and epicardial origins. I think that makes our procedure probably more focused, and we know what you're getting ourselves and the patients into. And lastly, I want to share with you that picture. You've probably heard about CardioInsight having done that already, but actually this Vivo system has been used now as well for non-invasive catheter ablation. So not only locating where it's from, but also without putting catheters in the heart, ablating a VT exit site. That is now done in the University of Maryland. Tom Dickfeld and colleagues have done that very recently, and we hope, and so far we heard the patient as well. And I hope that's going to be the new era for us electrophysiologists, that we don't have to spend 10 hours in the difficult VT case, but maybe we can do non-invasive ablations in the near future. So I think invasive mapping is great. Non-invasive mapping is even better. Thank you very much for your attention.